Good afternoon and welcome to today's presentation, Overuse, Musculoskeletal Disorders and Work. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law sans the expert's consent, i.e. a business relationship where she or he is hired for a particular case. In today's webinar, Ms. Marks will discuss impacts on workforce, examples of MSDS, the definition of carpal tunnel, the meaning of tennis golfer's elbow, if equipment change is enough, ergonomic workstation, legal implications, and what we know. To give you a little background about our presenter, Elisa Marks is a practicing occupational therapist and certified hand therapist in Pacific Palisades, California. She has been in the practice 20 years. Additionally, she is a certified ergonomic assessment specialist. Elisa has been involved in both defense and prosecution cases as an expert witness. She loves to teach continuing education seminars for hand therapists and has authored several ebooks. Elisa has been published in the Journal of Hand Surgery and has been a contributing author in several occupational therapy textbooks. Attendees who require a passcode, the word for today is tunnel. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will be sending out an email with a link to the archived recording of the webinar. The slides can be downloaded from the resource list by checking the link at the bottom of your screen. Thank you all for attending today. And Elisa, the presentation is now turned over to you.
Good morning and good afternoon, depending on where you're located. Thank you so much for having me today. As they said, I am a practicing occupational therapist and specializing in the area of hand therapy, which includes the hand, shoulder, wrist, elbow, and all the entire upper extremity. As part of my work, where I'm in a private outpatient clinic, many of my clientele comes in with overuse and musculoskeletal disorders. And there's often some concern as to whether it should be a work comp case, not a work comp case, what the implications are from their work and or their daily routine as related to the symptoms they are experiencing. Over the years that I've worked with these clients, I've taken a special interest in ergonomics and the way people's workstations and work environments are set up productive and meaningful for people to be able to work without having pain. And so I also go to people's homes and offices and do ergonomic assessments of their workstations. Today we'll talk about the impact on the workforce, first of all. And so OSHA, or the Occupational Safety and Health Administration, reports that there's a $20 billion impact on our workforce. According to OSHA and the U.S. Bureau of Labor Statistics, the most common repetitive stress injury is carpal tunnel syndrome. Carpal tunnel syndrome affects more than 8 million Americans. This is that nearly half of all carpal tunnel syndrome cases cause workers to miss 31 days or more of work. Now, your average repetitive stress injury is 23 days. So that's looking at the broader amount of things beyond carpal tunnel. Carpal tunnel in particular causes a longer loss of work. And on average, most worker comp injuries cause only 9 days loss of work. So we can see that repetitive strain injuries, also identified as musculoskeletal disorders, that's the MSD terminology, cause people to lose a significant amount of work above the average loss for work-related injury. In 2012, the incident rate overall for musculoskeletal or repetitive strain injuries was 3.0 incidents per 10,000 workers. So it's a very significant impact both economically and productivity-wise on our employers in the United States. An estimated 260,000 carpal tunnel syndrome release surgeries are performed annually, and 47, or almost half of these cases, 47%, are considered to be work-related. So the bottom line is that this is a huge part of our economic impact. It's a huge part of our workforce. It's something that people that you guys are seeing are dealing with each and every day. So musculoskeletal disorders is a very broad term. It describes a huge swath of diagnoses. These include carpal tunnel syndrome, which is the one you hear about most commonly in the press, although many people that complain of carpal tunnel syndrome because it's the only one they've heard of may incorrectly assume that their symptoms are carpal tunnel. There's tennis and golfer's elbow, which can be caused by work-related tasks, doesn't necessarily have to be related to tennis and golf, despite the nomenclature. There is tenosynovitis, which may be dequer veins and trigger finger. People can have myofascial pain, shoulder tendonitis, neck and back pain. And then the media has coined some terms that you may see that are kind of catchy and cute, called blackberry thumb, although as we have less blackberries in the mix these days now, people sometimes call that texting thumb. There's also sit, slump, slouch posture issues. You may see things referred to as cell phone elbow, smartphone slump, or snapping thumb. All of those are actual diagnoses with cute names, but they can be boiled down to the underlying problems that are an actual definable diagnosis. In the image that you see below on the bottom right-hand corner of the screen, if you zoom in, what it's showing is the more we bend our heads to look at our devices, the more the weight of the head is amplified. So in a normal posture, our head should weigh about 10 to 12 pounds on the rest of our spine. As we bend over more, that can amplify to 40 or 60 pounds. And in this sort of cute take on that, our head eventually gets too heavy and falls off, which hopefully hasn't happened to any of your clients. So let's dig down into the nitty-gritty of what a few of these diagnoses mean, because people may come in and say they have carpal tunnel when their symptoms may be indeed a musculoskeletal disorder, but if the terminology is wrong, that's not going to get us very far. Carpal tunnel is by far and away the most commonly referenced of the musculoskeletal disorders. And so carpal tunnel is a compression of a median nerve in the wrist at the carpal canal. So what that means, if you look at the picture below, if you can see it, the sliced view, so that's looking into your wrist, the little oval-shaped one, that's looking into your wrist as if you cut off the hand and you started looking into the wrist or into the hand. That cross-section shows that there are blue tendons and one yellow. The yellow nerve fits in that tiny space with all of the tendons, and so if there is any swelling or compression on that area, that little yellow median nerve is going to get squished. And I very much liken this when I talk to people about using your garden hose. So if indeed you're using your garden hose and the water stops coming out, you look back behind you to see what the problem may be. And in all likelihood, it's gotten wrapped around the leg of your patio chair or some other obstruction. Or conversely, maybe your kid is standing behind you and has accidentally stepped on the garden hose. This is very much like what happens to the median nerve in this carpal canal. If you are leaning on your wrist and squishing that yellow nerve as if leaning on the edge of a desk, that median nerve cannot get the blood flow it needs to communicate to the hand. Or if you are bending your wrist at a funny angle, it is like kinking your garden hose around the leg of a chair and the water cannot come out. So in both those circumstances, you are causing damage to a physical structure, and the structure is not able to function properly. What is the impact of this? For office workers, they can complain of difficulty in handwriting. The most common complaint you may hear is numbness or tingling in the thumb, index, middle finger, and sometimes even the ring finger. If you look at the photo in the bottom, the fingers that are highlighted a little or colored a little bit darker skin tone, that's what the median nerve innervates, meaning that's the sensory the area of sensory reception that the median nerve controls. So it's actually half of your ring finger, all of your middle finger, index finger, and thumb. So people will feel intermittent tingling, numbness as the compression or problems with the median nerve progress. This may lead to a more permanent, constant tingling or numbness as opposed to intermittent. Because you aren't feeling properly and you're not getting the proper input in your fingers, often folks complain of dropping things. They often also complain of sleep disruption, which may indeed be positional in that they're bending their wrists in a fetal position. People often also complain of tingling with driving. That is not uncommon because of the position people's hands are in on the steering wheel. How do we assess carpal tunnel syndrome, or how would a physician assess carpal tunnel syndrome? The most common two ways are physical exam and nerve conduction studies. Nerve conduction studies are the best available test we have, and they're not that great, frankly. They have a pretty high rate of false and false positive results. So what we mean by that is a false negative would be that they get the nerve conduction study, which is a somewhat uncomfortable electrical test, and the test comes back and says there's no carpal tunnel, when indeed the patient is experiencing numbness in the thumb, index, and middle. They are complaining of all the stereotypical kind of cookbook things of carpal tunnel. A false positive would be where somebody has this test, says they have carpal tunnel, but they're not experiencing any symptoms. We don't see that as much because people generally aren't going for this test unless they have symptoms. The false negative rate is not terrible. It's more than we would like. Unfortunately, or fortunately, this is the best test we have, even though it's not fantastic. In the medical record, you will often see that physicians do something called Phalines or Tinels. That's most commonly cited. Unfortunately, the more and more research we do on these two particular manual tests that a physician can do in office, they just don't have strong correlation with an actual carpal tunnel syndrome. But yet, they are still commonly used. There is a newer test that is getting better science behind it, and it's called the Scratch Collapse Test. And so if you see that in documentation, the Scratch Collapse Test is actually a pretty well-documented test that has a stronger correlation with actual carpal tunnel, also cubital tunnel, which we're not going to focus on too much today, but is a similar compression at the elbow. We're going to move ahead to the next slide. Sorry, my computer is working a little slowly here. So what would we do if somebody has, what are the appropriate treatment steps for carpal tunnel? Most physicians will request, hand therapy and conservative treatment unless the nerve conduction study comes back that it's a really severe case or the patient is just so disrupted by their symptoms that they just can't function, in which case they may skip the conservative stuff and go straight to surgery. The conservative treatments include a variety of hand therapy interventions, such as soft tissue mobilizations, physical agent modalities, education to the patient about ergonomics, body mechanics, the positioning issues that come with this diagnosis. And then also, one of the most common things you will see is that both physicians and therapists recommend the use of wrist splints or braces. It's very commonly the kind you'll see like supermarket checkers wearing. It's just the basic wrist splint. You can buy them over the counter at any drugstore or medical supply store. They're usually $15 to $30. They're very inexpensive. What this does is it keeps the client's wrist in neutral posture. So they are not getting compression on that nerve or bending of their nerve. They're not stepping on their garden hose or kinking their garden hose. The other thing we will do in conservative treatment, we might use kinesio tape and different interventions of mobilizations, nerve gliding, and other such things, as well as talking to the client, or at least I do, about the ergonomic modifications they may be able to do at their workstation in order to improve their symptoms. If none of that is working or not working well enough, occasionally physicians will do a cortisone injection as sort of a stopgap measure or temporary intervention. It usually doesn't buy the patient more than a few months of relief, but it can buy time. And then additionally, they do carpal tunnel release. A carpal tunnel release is basically where they cut the ligament that causes the top of that tight tunnel where we saw that picture with all the tendons and the one yellow nerve. They basically cut the roof of that structure. It's a very short, carpal tunnel is a very short surgical procedure. By cutting through that ligament, it opens up the space just enough in there that everything has more breathing room and the nerve can start sending more regular signals again. There's a very high success rate with carpal tunnel release surgery. Not perfect, but it does have good success for a large portion of our clients. And the procedure itself is super fast, like maybe 15 minutes. And it's one of the more common procedures hand surgeons do. To our next slide. What is tennis or golfer's elbow? This is an overuse injury of wrist extensors. Tennis elbow can also be known in the literature or in the notes as lateral epicondylitis, or if it's your wrist flexors and golfer's elbow, it's called medial epicondylitis. For both of these syndromes, the person would have a significant pain at the bony area in their elbow. So if you're sitting there right now and you run your hand around your elbow, not the point of your elbow where you flex and extend, but around on either side, you'll feel a bony nub. Those are the areas that are implicated in tennis elbow and golfer's elbow. People have difficulty doing grip or repetitive forearm rotation, such as using a screwdriver in this diagnosis. Both of them have tenderness to palpation at either one side or the other side, as you can see in the picture, of that bony nub. For tennis elbow, the patient will be painful with resisted wrist extension. They will be painful with resisted wrist flexion for golfer's elbow. The tricky part about these is it's diagnosed all through physical exam. There is no significant imaging or lab tests that will identify. You can't take an x-ray and decide somebody has tennis or golfer's elbow. The treatment for these two diagnoses are very commonly therapy. And in therapy, we do a variety of different protocols on stretching. When it's appropriate, we'll do strengthening. And then one of the things you see most often is people either recommend a counterforce brace, which is what is in the picture, or a wrist brace. With tennis elbow in particular, which is the more common of the two diagnoses, it is from overusing your wrist extensors. So if you touch your elbow, once again, and you go on the top of your forearm. So on the top of the forearm, like if you trace down from where your knuckles are all the way down towards your elbow, there's a big mass of muscle there, a big meaty muscle part. If you rest your opposite hand fingers on that meat and you lift and lower your wrist, you'll feel the muscle contracting under your hand as you lift your wrist every single time. Those are your wrist extensors. And if you use them too much, the force of that lifting goes into the elbow and causes pain. So we can use either the counterforce brace you see in the picture, which disrupts that force as it's going up the elbow from a physics perspective, causing less force to go into the elbow, or I sometimes prefer a wrist brace on the client in order to limit how much wrist extension they can do in the first place and give that area a nice rest so that the swelling and inflammation from the overuse can settle down. Physicians often do cortisone injections, and often these cortisone injections may require a series of 2 to 3 to be fully effective. The other thing I talk about very, very regularly with clients is ergonomic modifications as well as body mechanics in order to help relieve the symptoms. Now, we often hear, well, I was doing this kind of job and it's so repetitive, and of course, that's what led to my symptoms. But what does the scientific research say? Are there certain occupations that are linked to musculoskeletal disorders or overuse? In the Rheumatology Journal in 2012, it did show that certain tasks are linked to carpal tunnel. Those tasks are not necessarily office tasks. Occupational exposure to excessive vibration, increased hand force, and repetition together increase the risk of developing carpal tunnel syndrome. Where your wrist posture was, interestingly enough, is not statistically significant. So we talked about the idea that when you have carpal tunnel, it is often caused by poor wrist posture in terms of, are you kinking your garden hose by keeping your wrist bent forward or backward all the time. According to this study in the Rheumatology Journal, wrist posture was not significantly a problem. The Journal of Clinical Biomechanics in 2015 has a study that showed typing tasks cause changes in that median nerve, that yellow guy we saw in the cross-section. And the changes are influenced by the level of ulnar deviation. Now, we haven't talked so much about ulnar deviation. If you put your hand on the tabletop flat in front of you or on your lap, and you tilt your left hand towards the pinky side as if it was like a windshield wiper, that is ulnarly deviating your hand. People ulnar deviate on their keyboard when they're going to hit keys on the far left or far right side of their keyboards. So this study showed that the median nerve can be kinked or stressed by the level of ulnar deviation, and that the median nerve is showing those changes until the cessation of the activity. However, it is unclear if those changes led to long-term symptoms or long-standing or any kind of nerve injury other than in the moment. But it does add to the evidence of a possible link between carpal tunnel syndrome and keyboarding. Another list that I found, which is from a 2006 rating from the Bureau of Labor Statistics, from highest to lowest about the amount of people reporting a carpal tunnel syndrome event by job. And the highest ranking job for reporting carpal tunnel issues were laborers, freight, stock, and material movers. And as you can imagine, lifting repetitively heavy boxes puts a lot of strain on your wrist. The second highest ranking was for customer service representatives. So those people would be typing and doing a lot of email response and such. Managers of office and administrative support workers, janitors, maids, and house cleaners, food service managers, first-line supervisors and managers of retail sales force, automotive service techs and mechanics, executive secretaries, financial managers, sewing machine operators. And then as we go down the list, we go through truck drivers, office clerks, packers, computer engineers, which I would have thought would have been higher, but is surprisingly lower on this list. Stock clerks, tire repairers, packaging, and filling machine operators. So it just gives you a look kind of overall of the different jobs in our society and where they fall by as they're implicated with carpal tunnel syndrome. So interestingly, when you look at carpal tunnel syndrome, because everyone tends to think it's a work-related injury, an occupation, most studies have found no causation between carpal tunnel and keyboarding. So there was a study in the Journal of Occupation and Environmental Medicine in 2014 that looked at a whole bunch of studies. There was no significant evidence that pointed towards keyboarding being linked to carpal tunnel. Carpal tunnel is loosely associated with vibration, increased hand force, and repetition together in common. But it is far more common in non-computer use jobs such as assembly lines and factory workers. However, I will tell you that a significant number of my clients complain that they are experiencing symptoms when they are on their machine, and when they go to Hawaii for a week, magically the symptoms go away. Or when they have a long weekend with the kids and they're out at baseball practice and all those other things, the symptoms go away. So anecdotally, I'm sure you hear from many clients, as do I, that the symptoms are present when they are working and the symptoms are not present when they are not working. So then we look at, can we change the equipment they're using in order to make a difference? And that's what I do when I go to someone's workstation at their home office or at their workplace and look at how are they currently seated at their workstation, what are the changes I can make to make it a workstation that aligns with their body better. And this is not a cookbook thing because, as you can imagine, people come in all different shapes and sizes. So no one workstation is right for everybody. I'm very petite, tall, and super tiny. I almost need a pediatric workstation. My husband, who's more normal sized and 5'10", needs a grown-up workstation. And that's going to be different than somebody who is 6'4" and 250 pounds. So we have to look at how do these environments we're creating fit the people we're stuffing into them. So an ergonomic workstation is a workstation that allows the user to work in an optimal posture without causing undue strain on the body. The factors we need to consider are the angle of the wrists and elbows. These are the ones related to the actual workstation. Angles of wrists and elbows, hip and knee angle, height of monitor, and the use or non-use of armrests, neck rests, foot rests. But additionally, we need to look at how long is that person sitting without taking a break, because that will also, even in the best of workstations, if someone's stationary for too long, their body is not going to be happy. Our bodies were not designed to sit still for 10 hours a day without moving. As we come from our hunter-gatherer roots, we need to move. And our bodies over hundreds and hundreds of years have used to work in much more manual and more mobile fields, and now we are much more sedentary. So as we think about what is ideal for our bodies, we need to think about the fact, again, that no right piece of equipment is for everyone. So when I look at somebody and I assess whether their workstation fits them, I look at injury and pain history. The vast majority of people do not consider getting an ergonomic assessment until they are already injured. So I need to look at what is that injury and how does it interplay with their workstation. I also try as best I can to include consideration of their budget or their employer's budget as to the suggestions I make. What kind of space do we have? If we're cramming this person into a little tiny cube, we may not have as many options on how to adjust things as if the person is building out a new workstation from scratch. Are they right or left-handed? And what are the demands of their job? So a workstation designed for somebody who's a graphic designer is going to be very different than somebody who's a customer service representative. We need to look at things like, are they in accounting? Do they need access to their 10 key, which is that little, on a regular non-laptop keyboard, are the numeric pads usually to the right? Some people, financial traders and others, may need multiple screens, especially if they're dealing with international markets. A study in 2000 in the Journal of Occupational and Environmental Medicine looked at 273 users of computer workstations. The musculoskeletal disorder risk increased in the following situations. For wrist and hand pain, so there was an increased risk of wrist and hand pain, specifically in females, people that worked greater than 7 hours a day, or people with poor keyboard position. There was an increased risk of complaints of neck and shoulder pain if people were working greater than 7 hours a day, again, if they were over 40, and if they were infrequently taking breaks. So again, that comes back to the idea of how long are we sitting still for. There was a study, another study in applied ergonomics in 2013 that looked at workers in a lab-controlled environment, and they had them working 8-hour days for 15 days. One of the groups received ergonomic training, a sit-to-stand desk, which we'll talk about a little bit later, and reminders about movement and ergonomics. The other group received minimal intervention. The trained group varied their postures throughout the day and had significantly less discomfort. So that comes back to the issue of how much are we sedentary during the day and how much are we moving during the day. In ergonomic workstations, so this is another Cochrane review. A Cochrane review, as many of you may be aware, takes a look at all the studies in a certain space to try and come up with one final conclusion. And they only pulled the best quality studies that meet a very high standard, and then they draw all those conclusions together in one final finding. So they looked at ergonomic design and training for preventing work-related musculoskeletal disorders of the upper limb and neck in adults. Their finding, the Cochrane review, which is highly regarded, is that there is not enough high quality to determine the effectiveness of ergonomic interventions. And the photo that you'll see at the bottom half of your screen shows what most ergonomists consider an ergonomic, a good quality ergonomic posture. So this is sort of my starting point for people. Or if I'm seeing a client in my office for carpal tunnel as through their regular health insurance, but they report that they feel like their workstation is causing a flare-up in symptoms, I will have them email me photos of their workstation, and we'll kind of work through it together, and I usually give them a graphic similar to that to help them start adjusting. The Internal Archive of Occupational and Environmental Health in 2014 showed the effects of ergonomic intervention on work-related upper extremity musculoskeletal disorders among computer workers. And this was a randomized controlled study, which, as many of you know, is sort of considered the higher vanguard of types of studies. So they looked at 94 subjects with a 6-month follow-up, and it showed complaints of workplace upper extremity pain decreased significantly compared to the control group. So body posture and workstation layout improved. The people that had this intervention had 2 interactive sessions, ergonomic adjustments, and an education brochure. We're going to go to questions here in a second, our first round of questions. But I think what we'll see time and again throughout this talk today is that there is science out there that can support the need for or the success, I should say, of ergonomic intervention. There is not an overwhelming supply of that evidence. So you could somewhat argue either way. Most of the therapists that I know in my space and in a lot of our presentations at our seminars and our conferences will talk about ergonomic interventions, and anecdotally, many of them will tell you that once you've done an ergonomic intervention on somebody, they tell you right away that their symptoms relieved. So I think there's a lot more science to be done in this space, but I also do think there is a role for ergonomic intervention. We'll take some questions now.
Okay, thanks, Elisa. If all the attendees can enter the passcode for today, the passcode is tunnel. You can also enter in your questions that you would like for her to ask you. Also, just a reminder, please remember, if you are applying for CLE credit, you must attend the full 60 minutes of the presentation as well as complete the survey given at the end of the presentation today. Our first question, what qualifies someone to be evaluating worker ergonomics at a corporate setting?
Thank you for that very good question. There is a wide variety of groups that certify ergonomics. Unfortunately, there is not one particular standard. I am a certified ergonomic assessment specialist. There is also certified ergonomists. There are 3 to 4 different groups that are sort of well known in the space as best certifying people that they've had additional training and expertise in this arena. However, what you will hear from your clients all too often is that somebody from HR came up and adjusted their workstation. So many times when I ask what the credentials were of that person, it turns out it's an HR person who went to half-a-day training on or what is considered kind of cookbook ergonomics. And often that person has no background in injury or medical issues. And so therefore, they're not necessarily adjusting that workstation to an injured worker. They're adjusting that workstation to sort of that little diagram I gave you. That's a good starting place, but it's not a one-size-fits-all workplace. And more often than not, I have found that people get that HR sort of representative person. There are companies out there that have in-house ergonomists or consulting groups that are ergonomic specialists that come in and will look at somebody's workstation. But it is worth the deep dive into the question of what are the credentials of the person that is evaluating your client.
Next question. Is carpal tunnel syndrome the result of sclerosis? If so, does sclerosis ever reverse itself by eliminating the repetitive motion that caused it?
I'm sorry, I didn't catch the beginning of the question.
Is carpal tunnel syndrome the result of sclerosis? And if so, does sclerosis ever reverse itself by eliminating the repetitive motion that caused it?
Was the question sclerosis? Is that the word you used?
Yes.
Okay. Carpal tunnel syndrome, as we talked about, is a compression on the median nerve. It is an issue with blood supply to the nerve and inflammation around the nerve. So the repetitive motion part of it, which I didn't stress as much as the positional stuff, and I hear you on that. The repetitive motion, so if you're using those 9 tendons that are in the carpal tunnel, the blue ones versus the yellow one, from that graphic we saw, if you're using those repetitively and too much, they can inflame. And as you saw, that space prior to surgery is very snug. And so if there's any inflammation in those tendons, then they are therefore squishing the yellow median nerve. So it's a tight space. Everyone's packed in there really tightly. If anybody blows up a little bit, they're taking up even more space, and it's like shoving your foot into a shoe that it doesn't quite fit in. You can jam it in there, but eventually you're going to get a blister. So very much so, the nerve starts to get squished. It's like stepping on your garden hose. That's from the repetitive use of the tendons. Now, the question is, can it ever be reversed? So mild to moderate carpal tunnel has some good success with conservative interventions. If you eliminate the problem that is causing the lack of blood supply, nerves are pretty impressively good at healing. However, if the carpal tunnel syndrome has progressed to a stronger, more moderate or severe case, a lot of times even the conservative interventions will not be successful, and the person will need surgical intervention, and any surgeon will tell that person if the damage is too far along, it may become permanent. So even if doing the carpal tunnel release on a severe case will get probably some improvement, but no doctor will be able to predict for you how much improvement. Now, that being said, I've had patients with severe carpal tunnel that get almost all of their sensation back and are super happy. And then I've had clients that have severe carpal tunnel and get some result, but not as much as they would like.
Next question, what is involved in an office ergonomic evaluation of the workplace? Is there a typical cost?
I know what I charge for a workstation, and I believe it's fairly typical for my Los Angeles community. I don't know the pricing outside of my local community. I charge $225 to go to somebody's office for 1 hour, up to 1 hour. And in that evaluation, I look at everything from, and we'll talk about this a little more, but everything from height of the chair, location of the screen, what kind of mouse are they using, where is their keyboard, are their feet planted well, and then I will, at their request, go back for a follow-up once they've made the interventions that I've suggested, because sometimes that involves buying equipment, so it may take some time for them to purchase the equipment, get it installed. I will go back at a prorated amount to look at that workstation in its new and improved format if they so choose. And I also will print up a report of the suggestions I've made. I usually list in there multiple price point options. Like if I'm suggesting that I don't think the mouse they were using is the most ergonomic mouse for them, I will list, here's 3 different mice you can try. I also, when I go on site, take a big trolley that I have full of different sample equipment, and we might even try some of that for size briefly while I'm on site. Next question.
And our next question for this section, is standing up and moving ever so often a good preventative for most sitting injuries, other things being equal?
Great question, because as soon as we're done with the question section, our next slide is titled, Is Sitting the New Standing? So we are going to get to that about whether sit-to-stand workstations, whether sitting is better, so just hold tight on that one.
Okay, thank you. You can continue with the presentation.
Well, that was an excellent segue then. Is sitting the new smoking? Most studies that are looking, so to the question that was just asked, if we have a sit-to-stand workstation, which you can see pictured there, if we move throughout the day between a sitting and standing posture, are we going to get less injury? Many are showing a positive impact on activity levels and cardiovascular status. But none of these studies, because this is a relatively new arena, not a lot of these studies are 5 or 10-year studies. They are finding, some people thought, well, if they're adjusting their workstation all day, then they're going to lose productivity. People are not showing there was any loss in productivity, and some folks are actually showing an increase in productivity related to movement. And there are some studies showing out there that there is decreased musculoskeletal complaints. However, if somebody is just standing all day, that is going to cause a different set of problems on their back, on their legs. They may need an anti-fatigue mat. So the bottom line in answer to your question is, yes, we need a variety of movement throughout the day. Without a variety of movement, we are going to have issues. Now, can I promise you that if somebody has a variety of movement, it's going to solve all these problems? No, it depends. The dosage of movement is important, but there is an increased push in the ergonomics community to do walking meetings, to have people take phone calls on their headsets and pace around their office while they're doing it. You may have even heard of treadmill desks. And treadmill desks run at an incredibly slow rate, so you're not going to be trying to multitask and not fly off your treadmill while you're working on a laptop that's like sitting on the display part of your treadmill. Obviously, that would create wrist fractures and all other sorts of things that you could represent people for. But they set them really, really slow, so people are getting steps throughout the day at a very slow pace, and there's been some evidence that shows that that is an increase in productivity. So coming back to where does this leave us at this point? What do we know? Reports of workplace musculoskeletal discomfort are very significant. Many of the postures used at a seated workstation or with mobile devices put undue strain on the body. Ergonomic adjustments may help, but there is some evidence that show they may not. Sit-to-stand workstations do not decrease productivity and help to decrease the effects of sedentary behavior. Because of the limited time today, and I want to get to some legal fallout from all of this, I haven't put a big stress on mobile devices, but mobile devices often cause an even worse strain on our bodies. Mobile devices, especially the laptop, was originally invented in order to help people work in a hotel room or on the go, but not as their primary device. As our society has evolved with our technology, iPads, laptops, and phones have a lot of times become the primary device for people. One of the things we know about ergonomics is that original picture that I showed you in the beginning where the guy's head fell off. If we are keeping our necks craned down all the time, it is putting a significant stress on the spine. So we need, when I do an ergonomic assessment, when most people do an ergonomic assessment, one of the things we look for is that the eyes, if you're looking straight out at your screen, should fall on the top third of our screen. Most of your work when you're searching on Google, when you're writing a document, occurs in the top third to top half of the screen. So we want our eyes, if we're intending to keep our neck in a good neutral posture, to be lined up with the top third of our screen, or the top of the head with the top of your screen is another way to look at that. And then the keyboard should be very close to your lap, almost hovering above your lap to keep your elbows and shoulders relaxed and wrists in good posture. If we have a laptop, we have to sacrifice something. We're robbing Peter to pay Paul. So if we are keeping our screen where our eyes are falling in a good posture, a third of the top to the third top half of the screen, our arms and wrists are going to be jacked up really high to get to that keyboard. If we keep the keyboard down low, our neck is going to be craned down to see the screen. All that changes a little bit. Also, if you're dealing with bifocals is another consideration we think about. So when we're using a mobile device such as an iPad or a laptop and people primarily use those devices, I start to talk to them about using a separate keyboard and separate mouse and finding a way to set that up so the screen is high but the other stuff is low, just as an aside there. So what is the role of a hand therapist and what does that even mean? For those of you that are considering using a hand therapist as an expert witness in some of these cases, a certified hand therapist is a person who is skilled in assessing pain and discomfort and treating pain and discomfort or illness or injury of the upper extremity. Someone who has a CHT credential has passed a rigorous board examination that attests to their depth of knowledge of anatomy, physiology, surgical and non-surgical issues from fingertip to shoulder. Not to the same extent because it's only 4 hours and not 3 days, but it is our version of the bar exam for hand therapy in particular. So CHTs can be physical or occupational therapists who have met a certain percentage of that in their career they've worked a certain amount of areas specifically related to upper extremity therapy, that they have been in the field for a certain amount of years before they sit for the exam, and then they sit for this rigorous board exam that they say approximately half the people pass on the first go-around. So it really weeds out those folks who have not met the highest level of credential in this arena. A certified hand therapist or CHT has the education, board certification, and clinical hours to provide meaningful review of medical records and provide insight. Many CHTs have experience in ergonomics and may have an ergonomic certification because these diagnoses are so prevalent in our practice. A CHT can help examine a workstation or work environment to see if it meets general safety guidelines for ergonomics setups. When people do their ergonomics training, it is often not just the narrow focus of office workers. When I took my CHT training, many of the cases we studied included like a Purdue chicken factory for killing and packaging chicken parts for sale. It can include a variety of auto mechanic factories, all different sort of hospital settings, the ergonomics of somebody like a nurse or a home health or LPN who's doing a lot of lifting and different things like that. So ergonomics affects a wide variety of occupations, but in this, my focus, I tend to focus on office environments because so many of my patients have repetitive strain and musculoskeletal disorders. Sorry, my computer is having a bit of a freeze for a moment, but we are going to get to the legal issues in 1 second. I don't know if, Rochelle, you can advance the slide for me because my computer is having a bit of a wig out. Thank you.
Sure, that's fine.
Okay. Thank you. It's a little slow here. There we go. Okay, so I'm going to discuss 2 different cases today just to let you know a little bit about how there are legal issues surrounding these types of musculoskeletal disorders. There is, interestingly, not as much law as I would have liked, very specific to office workers, although we will look at one case of that today. This issue is around the company of Caterpillar. They were fined $900 by OSHA, which is the Occupational Safety and Health Office from the government, for not reporting any particular injury. This is sort of an overview here. Caterpillar appealed because their panel of experts at the company said the injury was unrelated to the person's work. An administrative law judge upheld the fine, and they appealed to the 7th Circuit Court of Appeals. The 7th Circuit, when they looked at this case, said that the person that was there in this line of work had been there a long, long time, and multiple people had been in this line of work for a long time, and Caterpillar had never, ever had somebody have a case of epicondylitis. So if you have all these many people working on this assembly line and doing these particular jobs, and there's never been a case of epicondylitis, it is not likely work-related, because if it was work-related, everybody would be having epicondylitis. So that's what the 7th Circuit said, and they returned it to the administrative law judge to ask them to reconsider. But the administrative law judge stood by their decision because an expert from OSHA, they liked the Caterpillar experts' information better than the OSHA experts, and they sent it back again to the 7th Circuit. The 7th Circuit did not agree and threw out the fine. So there are mixed findings on the culpability of office work in causing carpal tunnel from a legal perspective. We're going to look now at the case of the Appellate Court of Illinois and the Work Comp Commission. So it's Davis versus the Illinois Workers' Comp Commission from last February. You'll see that they concur in judgment. They were seeking work comp. The plaintiff was seeking work comp for bilateral carpal tunnel that she says was caused by work-related repetitive trauma. And that was initially approved. But the employer appealed, and arbitrator's decision reversed and denied her benefits, saying she could not prove a link to her employment. So the claimant requests a judicial review. The woman's job included a mix of activities. She worked as a victim's advocate. So she did a lot of data entry and reports via email on what happened in court. She also went to court meetings and did phone calls. So one doctor that was involved linked her symptoms to work. A second doctor stated there was no evidence that the carpal tunnel syndrome was work-related. She was therefore denied. The court did not agree that keyboarding was linked to her repetitive, that they said that keyboarding was, it's not that keyboarding was never linked to repetitive motion, but they did not feel that this particular claimant had enough backing to say that her keyboarding was linked to her carpal tunnel. So their statement was that they didn't feel she identified enough typing throughout her day She also didn't identify any lifting or gripping or exposure to vibration or force. And that goes back to, or awkward hand positioning. That goes back to what we talked to of the science, the evidence-based things in the beginning of our seminar, in that most of the literature links you see to carpal tunnel include that in addition to repetitive motion, there needs to be vibration or force. So you think about jackhammering, you think about construction, those kinds of things, or any awkward hand positioning. So they said just saying that you're typing intermittently a lot on the day is not enough standing. To obtain compensation, they said, she must prove that some act or phase of her employment was a causative factor in her ensuing injuries. She must also show that she performed the same task in a repetitive fashion regularly or on a daily basis. When they looked at the job description for this employer, the job had no particular requirement for words per minute. So she could not turn around and say, well, if they make me do 120 words per minute, this many hours a day, that, of course, is going to cause my problems. The claimant used the Edward Hines precision components case to state that there is no requirement that a certain percentage of the day. So in this particular case, the court said that a certain percentage of the day needed to be spent. There was no requirement that a certain percentage of the day be spent on a task defined for repetitive strain. This commission said that is correct. We agree there doesn't need to be a particular like X equals Z, that there is a certain percentage of the day on a task for repetitive strain, but they didn't think she unleashed enough evidence to prove that she had repetitive strain, because throughout her day in this particular case, the woman was mobile because she was going to and from court. She was going to her victims' homes and workplaces. She was also taking calls, and she had a variety of tasks at her job. The points of contention in this case were wording at OSHA that said the work environment has to either cause or contribute to the resulting condition. Contributed to is a broad phrase, and the administrative law judge felt contributed to was intended to cover a variety of causal relationships. The Seventh Circuit felt there wasn't enough info to determine if the work contributed to her symptoms. And they felt that the lack of injury, the history of lack of injury, and a company's previous experience was an important factor. So if other people are not complaining of such, doing the same tasks, can we show that these particular tasks must indeed cause a repetitive motion injury? I will tell you that from an anecdotal stance, many of my clients do find significant improvement after we adjust their workstation. So what case do you have here? And where do you stand depending on if you are representing the plaintiff or the defendant? Evidence does not support the likelihood of carpal tunnel and tendinitis from a pure typing job. But if a job involves vibration, you have a better case for a causal relationship. The ergonomic setup may improve symptoms, but there's definitely you will struggle a little bit to find supporting medical evidence, although there is, or scientific evidence, but there is some scientific evidence out there. Legal cases do tend to support employers and saying the office job does not cause overuse, which makes your job a little harder if you're representing the claimant. Manual labor jobs would have more success in this arena. I will give you one sort of anecdotal example of a case I recently did, or I should say a evaluation I recently did. The woman is a office manager, administrator for her family business that does hardscape and landscaping redos of people's yards. She does all the phone calls, scheduling of bids, scheduling of work, billing, accounting. So she sits at her office in her home 6 to 7 hours a day doing all bookkeeping and computer-related stuff. She was experiencing neck, elbow, and back pain. She called me and asked me to come for a workstation assessment. Right away when I got there, one of the main things that we discussed is that when she took a phone call, she kept her phone cradled between her hitched up shoulder and her tilted over ear because she didn't use a headset. Additionally, her chair was not sized properly to her, so we made some adjustments to the chair. We raised her chair so she was more across from her monitor and looking directly at it. And then I suggested she also get a keyboard tray and a new mouse. I saw her a few days later in our community, and she said just the phone, getting the headset, and the adjustments I made were so dramatic, she had yet to even think about ordering a keyboard and a mouse because she was already feeling 80 to 90% better throughout the day. So just to show you, we can sometimes really see people's pain change when they get these interventions. What I also tell my clients is that they need to take what I call ergo breaks throughout the day. There are many apps out there that will pop up on people's screens or phones to remind them, oh, you've been at the computer for 45 minutes. Please stand up and step away for 2 minutes and do these 3 stretches, which is also helpful in getting people, as we talked about earlier, out of that sitting sedentary posture for all of those many hours at work. And now we will do our final round of questions. I hope you found that all very helpful.
Thank you, Elisa. If all the attendees can enter the passcode, and you can also enter in your questions that you have for Elisa. Our question is, what type of medical doctor specialist is best at evaluating these complaints?
There can be a variety of physicians involved in these kinds of cases. Often people will see a physical medicine and rehab doctor, PMNR, or physiatrist, those guys are known as. Many of my patients come directly from the hand surgeon because if they're developing hand, wrist, or elbow issues, a hand surgeon, an orthopedic or certified hand surgeon would be the person that they see. Some of these people come from neurologists since it is a nerve-related issue. Any and all of those would be, or an occupational medicine doctor, would all be appropriate physicians to be involved in these cases.
Next question, is there a particular app for a phone you recommend?
That's a great question. You know, I used to. There are so many that come and go these days. There is a great Facebook page, though, I will tell you, that I like, that is run by therapists called Sitting Solution. And they do, I have no affiliation with them, just to be clear, but they do pop up on Facebook with different exercises and things you can do to step away from your desk. But literally, if you go to the App Store and Google reminder breaks, there's so many that I stopped kind of following them because they come and go all the day, but there's a ton of them out there.
Next question, what factors outside of someone's work setting might be contributing to musculoskeletal overuse complaints?
So that's a great question because often it's really fuzzy if these are directly work-related. And I can imagine, as you all think about how much time you spend on Facebook, Instagram, Snapchat, all these things outside of work that may be related to your friendships, family, school activities, whatever it may be, charity work you're involved with, we're all on our devices for a lot more than just work. So indeed, it could be that this is compounded or caused by the amount of time we spend on the computer outside of our work things. And it is all too difficult to tell your clients that they also should be refraining from those activities. And someone will say, oh, I'm on the computer 8 or 9 hours a day for work. And I'm like, really? And then when you go home, do you start, oh, yeah, of course I go on Facebook when I go home. Well, how many hours do that? Oh, 2. So obviously that's playing into this. People that do a lot of needlework, like knitting, crocheting, I see those people often have issues because that requires a tight, sustained grasp with no release. Gardening can be a factor in this. Someone who does a lot of crafting. There are so many of our manual activities that we do throughout the day, but I will say I do think the biggest culprit sometimes is our use of social media and our devices for other reasons other than just our work. And we often do those in bed or on the couch, which causes our posture to be even that much more abysmal.
Next question, which area of the body do you see complaining about the most?
Oh, that's a good one. Anecdotally, I think carpal tunnel is my number one complaint. And that can be either the numbness and tingling from it or just a kind of diffuse wrist pain. Secondary to that, I think people get a lot of shoulder and neck, upper back discomfort. And so I would say that would be 1 and 2 for me.
And our last question, in your experience, can an ergonomic evaluation modification fix most people's pain complaints?
Most is a strong word. I think it makes a significant difference in their complaints. Fix is also a strong word. But that means that people also have to fix how they treat their body outside of that particular workstation. So let's say we fix their office workstation, but they go home to a crummy workstation that they share with their kids and their husband, so it's hard to adjust it to just one person, but then they do Facebook there for 2 hours. Obviously, that's going to be an issue. But I think if someone's really dedicated to getting themselves some relief and cutting back on those activities, and we fix their primary workstation, and their symptoms they haven't let their symptoms go so badly that they're really severe, I think in many cases it can resolve a lot of the issues they're having.
Thank you so much, Elisa, for answering the question.
My pleasure.
In addition to being your best source for test and science consulting experts for the past 60 years, TASA also offers e-discovery and forensic solutions, free interactive webinars, day-in-the-life videos, research reports on expert witnesses, including the Challenge History Report 2.0, Professional Sanction Search, and Expert Profile 360. Just a reminder, please remember that if you are applying for CLE credit, you must attend for the full 60 minutes of the presentation. You are also required to complete the survey at the end of the program. I want to take this opportunity to thank everyone for attending, and most especially Ms. Marks for her time and effort in creating this presentation. If you would like to speak with Elisa, or if you would like to speak with a TASA representative regarding an expert witness for a case that you're working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. Thank you for attending. This concludes our presentation for today.